look at, we know what the outcomes are through our quantitative work, but how did this happen, why did it happen, and what really worked and what didn't work. So I hope that will stimulate some discussion. So the objectives of the study were really to gather experiences, lessons learnt, best practices, but as well best fit practices, so looking at what worked in the specific context in which we were working, to effectively document what we did, really try to provide some, I guess, documentation and information to really guide future discussion on feasibility, acceptability and effectiveness for ICCM in practice. Promote participant learning and capacity building in evaluation methodologies in the countries we're working in, and really disseminate these experiences for the purposes of wider learning and also to support advocacy activities to encourage future time, focus, investment in this area, and to develop case studies which will again be disseminated nationally, regionally to add colour to in ICCM in practice. So a participatory evaluation approach is obviously one which involves the people who've been involved in the programme itself, so at planning stage, implementation stage, evaluation stage. It enables us to be context specific. What we did is we held workshops in each of the 3 countries where we brought together key people at different levels of the health system to help inform the overall scope of inquiry, as well as to inform who we should speak to and what we should speak to those people about. We went with one overall thematic framework, so looking at what we know happens in ICCM implementation, which is in part formed by the guidelines, by what our plans were, and added, so that's the deductive sort of top-down reasoning, essentially, and then added to that the inductive reasoning, which is the sort of more sort of bottom-up logic. So what we then had was one overall thematic framework, but then adapted to each of the country settings. Through the workshops, we agreed on the data collection methods, which ended up being beneficiary assessment, really informant inquiry at the local levels, stakeholder consultation and case studies. So the scope of inquiry for each country, these were the main key themes which cut across all different countries. The sub-themes beneath these were developed in country or came out of the analysis itself. Not all of these were included in each of the countries. E-health, for example, was just included in Uganda, but these were the key themes across all of the countries. What I'll do for the presentation is I'm going to pick many of these. I haven't got time to go through all of them in detail. There's 3 very large data sets from across the 3 countries, but what I've done is I've picked the ones which I think are essentially the most interesting and help us answer the question about how we can learn lessons from this which will inform discussions on feasibility, acceptability and effectiveness to take forward. The target groups largely were the same across the countries. At central level, we had the Ministry of Health, donors, Malaria Consortium personnel, partner personnel. At the sub-national level, so province, district, state, depending on the country you're looking at, the health management team at that level, different levels of the public health facilities, and then at community level, the community health workers, community leaders, and beneficiaries. Just one point of note from Helen's presentation, you'll know that they're called different things in every country. So we have village health teams in Uganda, we have Apejo in Mozambique, which we didn't include in this study because the implementation started later. The community drug distributors in South Sudan and community health workers in Zambia, but for ease, I'm going to call them community health workers throughout. So preliminary findings. At the sub-national level, introduction and startup, what came out very strongly was that the formal introduction from the Ministry of Health at the central level is really critical. So people have an understanding of how this fits into what the priority should be at that level, whether there are guidelines in place to guide it, etc. The collaboration in micro-planning is really valued, and it gives a chance to really think about integrating ICCM into local priorities right from the start, which is something that Helen really picked up on as well. What this looks like is really an agreement in how to integrate ICCM, as I say, into actual plans. Who's going to be doing what? How does it translate into support supervision? How does it translate into routine data collection plans and tools? But also looking at frameworks for collaboration in terms of sharing information, collaboration in terms of how do partners support specific activities, how will they be funded. So all of this needed to be very much agreed from the start, and this was something that was really valued. Community health worker recruitment and selection. What we found is that across all countries, the guidelines which existed for this were really followed, which is great, and meant that they were obviously reflective of how it should be done in country. We did find that there were less democratic approaches to selection which occurred in all countries, meaning that there were situations across all countries where community health workers were recruited which didn't follow the guidelines. And that was because there was either expectations there might be personal gain from it, such as from payment, where across all 3 countries there were no official fees for being a community health worker. And there were some complaints that there were related to tribal and political affiliations as well. What was very clear from the respondents, particularly from the community level, was that where the community were fully involved in the selection and they felt confident that it followed a democratic process in line with the guidelines, was that it did translate really into increased utilisation, much stronger support for the community health workers, and a greater sense of trust in the ICCM programme altogether. Where there was less democratic selection, people felt that it resulted in unqualified community health workers, so perhaps those who were too young, not literate enough, or didn't have the same sort of sense of volunteerism that's required to sort of perform well in that role, and did translate into less community support because people felt that the people who were chosen to provide that service weren't best placed. The key recommendations from respondents in this area were really to increase the emphasis on community sensitisation in this area. They felt that community leaders particularly were quite critical in being on board for the importance of adhering to selection criteria and ensuring a sort of democratic process. It was suggested that there should be more random or targeted monitoring of the selection process so that has a powerful incentive to follow the guidelines. There was little suggestion for revision of guidelines, but in Uganda it was suggested by quite a few people at the community level that a maximum age should be given. So people above 50 shouldn't be community health workers, mainly relating to the fact that they perhaps have less mobility and other things which potentially come with age, such as eyesight problems. I'm absolutely just talking about what the respondents said. Training and capacity building. We, as Helen has already mentioned, we adopted quite a few, we spent quite a lot of time on the training guidelines, working with key stakeholders in country, developing those materials and tools which reflected participatory and practical approaches. These seemed to work in that the community health workers really felt that they grasped the contents better, and by being able to, I guess, check their own understanding through application, through the training, their confidence was built through the training itself. In Uganda specifically, we did take the community health workers where we could to health facilities so they could observe danger signs to really try and reinforce what they looked like, which was really appreciated. Some of the tools we use were, in Uganda again, and I think maybe in Zambia, videos demonstrating chest indrawing and convulsions. In Uganda, we developed these little dolls, which you can see, which demonstrated rectal artesian demonstration. So you can see somebody is practicing that in a picture. The sick child job aid seemed to be really popular. People mentioned it. Often, many people actually mentioned it like their Bible. For easy reference, it was clean because it was laminated, and there was lots of good things said about that. The low literacy in South Sudan was a real challenge. For anyone who's worked in South Sudan and has worked at that level, you'll know that for community health workers, it's at a point where we had in the training to teach people how to hold a pen, and we had to teach people that when you have a tool and you have lines across it, you have to put data across each of the boxes in the line, and that was something which took quite some time to grasp. So you can imagine teaching something like ICCM takes a lot more time, it takes a lot more specialist training expertise and planning, and a lot more follow-up. Respondent recommendations in this area, they really focused on where to increase training emphasis. They emphasised identifying pneumonia compared to cough. There were some difficulties in distinguishing between those two. Using respiratory timers, there was some confusion remaining on that. Completing the registers, referral procedures, and particularly in Uganda, there was some overlap with how ICCM overlaps with newborn care raised some confusion. I think there's been more moves since then to kind of integrate those at the national level, but certainly that was something which came up. We know from Helen's presentation that training across the 3 countries, this focused on was 6 days long. In all countries, there was a big emphasis on extending the training duration. Most people recommending between about 2 weeks and a month, which obviously has cost implications. Regular refresher training focused on problem areas, and in South Sudan there was a big recommendation, a very common recommendation to include literacy and numeracy skills in training, which I think is something which is very challenging to do. But certainly I wanted to reflect that, given it was a common response. So moving on to support supervision. What seemed to come out clearly from across respondents, in terms of at the health facility and community level, was that when support supervision is delivered regularly and consistently and predictably, it does seem to have a very positive effect on community health worker motivation and performance. Conversely, when it's not done regularly, consistently, and it's weaker, community health workers really can feel discouraged and quite alone in addressing challenges. That's something we probably would have expected, but certainly our data really reinforce that. The home visits were highlighted as particularly beneficial. Helen again mentioned this morning that they're the most costly part of support supervision, but the benefits are really quite stark. There was lots of community health workers talking about the value of somebody coming to their home, seeing where they practice, giving them advice and particularly what they do. And I think just the reinforcement to them that somebody's taking the time to come to them, it reinforces to them that the job they're doing is important. Most of the challenges reported around support supervision were availability of funds, time required, availability of staff, workloads, the level of prioritisation health facility workers give to support supervision, difficulty in accessing community health workers due to poor roads during the rainy season, particularly hard to reach areas. This was particularly the case in South Sudan. And weak supervisors. Some supervisors or those health facility worker who have those responsibilities, some enjoy doing it, some don't. Some are more naturally skilled at supervision than others. So it's about thinking about how a lot of people suggested buddying up, where there was 2 supervisors who came, one was stronger, one was less strong. That seemed to help. But one thing that really came out was, which I think is useful for us to think about, is that supportive supervision there's a lot of routine challenges. There's things we know work and there's things we know don't work. And sometimes it's not about necessarily revisiting the model, it's thinking about how we can enable capacity, how we can sort of address some of those routine challenges and just make it happen, because really it's the regular contact which really does make a very big difference. So routine data collection. On the quality side, there was a whole range of responses here, and I think it's important to recognise there would be some bias potentially in some of these responses. Health facility workers generally said that the data was very good. Sometimes further up the system they said it was less good. Community health workers would generally say it was good. But there were still some people who would say that some people said it was 50% accurate, other people say it was excellent. So I think that probably the big summary, if you want to give a summary, is probably that it was acceptable. In Uganda and Zambia, where the context is slightly more similar in terms of capacity and the sort of process of data collection and submission, the inaccuracies in the monthly registers were reportedly due to poor numeracy skills, lack of sufficient training or recollection post-training, and human error. A lot of people were honest when they said, I'm too tired, I'm busy, I've got other things to think about. So I think it's important to recognise that does come into it, and therefore the value that the community health workers place on data collection and submission is really very important. In South Sudan, we did have challenges with the quality of data due to the low literacy. So as with the training, that was an area we had to put significant emphasis on to make sure that the support supervision and regularly and at different levels was there. Completeness. Where gaps existed, supervisors did tend to consult the community health workers to fill in the gaps. I've just put a note here that some people said, but of course we don't know what quality it is, because if the community health worker didn't include the data the first time, if somebody calls them and said, what was the data you didn't include, then adding data, you don't necessarily know the quality of that data. In Zambia and Uganda, community health workers did cite stockouts as the main reason for not completing registers, which we know shouldn't be a reason, because the registers need to be completed whether the drugs are there or not, but that did seem to be very much the case. And there were some challenges, certainly in Zambia at the beginning, where we had the ICCM tools at the community level, but there wasn't space within the HMIS tools to integrate the ICCM data coming up. And we found that the health facility workers really improvised, basically, and they did add all the cases in, but essentially when you amalgamate and you go up the system, the level of community cases was essentially lost. We've done a lot of work with the Zambia Ministry of Health to address this, so I think towards the end of the implementation stage, maybe Helen can add later if people have questions on that, I think it was much more integrated, but I think the integration is something which does remain a challenge, because it does put a much more, coming from the data again, it does put a much more pressure on the health facility workers to do that work, especially if the forms don't match exactly. In relation to collection submission of data, again, there were challenges in relation to funds, transport availability. Mostly the community health workers would walk to the health facilities to give in their data. So distances can be long, especially in the rainy season, especially in South Sudan. And when supervised did not appear to be available, so if there was no one really there to meet them when they arrived, or if they weren't getting regular support supervision, this really did discourage them, we found, from actually submitting data. So again, it's that linkage which is important. In terms of usage, at different levels, but particularly the subnational level and health facility level, there was a lot of people mentioning the need for more capacity building in this area. It's something that Malaria Consortium put a lot of emphasis on, but I think there's still a need to do more of it and on a continual basis. But people did talk about a range of ways they did use the data, which clearly does reflect the value people place in the data. Many of these were summarising the caseload for consideration of possible causes, responses. So looking at, say, if there was a particular rise in diarrhea incidents in an area, then they'd look at why. Is there any sort of hygiene issues which are going on, which are increasing the caseload over this period? Looking generally at the caseload against predicted numbers, why is that? Comparing the cases of diagnosis and treatment data, so looking at ACTs against RDTs, are those numbers matching in the way that we would expect them to? How does that give us an insight into community health worker performance? And looking at the quantification, consumption, looking at whether there seemed to be surplus supplies, stockouts, and how that was having an impact. So what we found that they were using the data in the way that we would hope. Sometimes it was less systematic than what we would hope, but certainly, unless we were sort of there giving lots of support, we may not get the overall trends and bigger picture that we would want. Routine data collection in terms of respondent recommendations, again, focused on the analysis and use of the data. People wanted more training, refresher training in that area. Ideally to link support supervision and data collection and submission if it wasn't already linked. And addressing the routine challenges such as funds availability, etc. And really looking at ways of how we can enhance community health worker value placed on the data, whether that be through feedback loops, ways of summarising the data, how to present it in an interesting way, how to get people to realise how that is relevant to them. So commodities and supply chain. Again, Helen touched on this morning the challenge of integrating the supply chain into the public health system. That was certainly our aim, and we achieved it in some part in relation to Uganda and Zambia. In South Sudan, it was harder because of the health facility and public the setup. So we did end up delivering directly to the communities. But this is something which was raised in terms of people recognising that that challenge. In Zambia, where the drugs for the national drugs and those drugs for ICCM were the same, there was a lot of interchange. So if there was drugs which ran out at the community level, it seemed that they would be replaced by the health facility level, which in some ways is positive in terms of that response. Stockouts. There were periods of stockouts at some points across the country, and so when you talk about stockouts, if there were stockouts, people would raise them. Community health workers and communities widely agreed that certain stockouts do absolutely affect people's perceptions on ICCM and community health workers. Having said that, all community health workers, not all, many of them said that where stockouts were a challenge for them, it did result in a higher workload because they've got their current cases coming to them, but as well they've got the backlog of cases who are still feeling sick or don't feel like their illness has been addressed, who continue to come back. I think I'm running out of time, so I'm going to move on quite quickly. Drug acceptability did seem to be high. Over time, people see that the same RDTs are being used at health facilities as at the community level. The drugs seem to be working. It builds their confidence in the work the community health workers are doing. And some of the recommendations relate to increasing quantities, more regular delivery schedules, and looking at the data over time in terms of consumption and improving quantification over time. Community involvement and support. It seemed from our respondents that ICCM was very much embraced. Utilisation was high, and communities seemed to support community health workers. There wasn't many incidents where they gave any financial support, but certainly we came across many instances where the community would cultivate small plots of land for the community health workers, so they did seem to translate into sort of acts of community support. The key barriers to referral, which we came across, were that the children, the caregivers may not realise severity of the illness, cost distant transport, long waiting times and concerns that the child may get more sick the longer they have to wait, cultural beliefs around cause of illness, language barriers, perceived or actual stockouts, and negative attitudes of health facility staff, particularly in the case of diarrhoea. People felt that they would be accused for not maintaining hygienic standards. So the key recommendation there is to really enhance, if we can, the sensitisation that communities, in terms of the role that communities can play in supporting ICCM. And finally, my last theme, which I'm going to talk about today, is behaviour change communication. The community dialogues were really highlighted as a key thing, which were really valued in terms of instrumenting change. And I've included a quote here, which I hope highlights that. When people talked about the value in BCC activities, they really focused on promoting use of community health workers, boosting their motivation, and encouraging trust in Western and biomedicine. That's what people tended to mention the most. And recommendations, really, it's about focusing on community structures. People felt that in comparison to some of the other BCC approaches, such as radio slots, more mass media, it was really those which involved going through the community structures which really were the most valuable. So just to bring my presentation to an end, just thinking about some key learnings from this, really I think we feel that qualitative studies can offer a value contribution in understanding the hows of implementation and contributing to discussions around how we can improve feasibility, acceptability in ICCM in practice. They can add a very strong complement to quantitative work. Participatory methodologies really enable a scope of inquiry and qualitative work to be very context-specific. So it's something which we would encourage. Community support to ICCM and community health workers really is necessary or essential for sustained health benefits. That really came out quite clearly across the different themes that we looked at. And a sharp focus really has to be maintained on capacity building and capacity enabling. So recognising what some of the routine challenges are and maintaining a continual focus on how we can address those of the public health system. Sorry for going slightly over my time, but I think that's the end of my presentation. Thank you.
Thank you very much, Claire. A round of applause. Okay, just to take a few questions, starting with any questions from online? Not yet. Okay. Questions from participants in the meeting? Yes, please.
Hi, Kate Henshaw from PSI. Thank you for the presentation. It was really interesting. I was just really interested in what you were saying about the community support for the CHWs, and with regards to what you were saying about the plot of land. If you could talk a little bit more about that, which country that was in, if that was something that was came about through the community dialogue, or how it came about, and if it's something that you think could have been sort of explored further.
Okay, Claire to respond as we move the microphone. Who's next? Karen, you had your hand up. Okay, Claire?
Shall I respond?
Yep.
Is my mic? Yes, it is working. You said the plot of land.
Yes.
Yes. That was something which particularly came up in Zambia. It also came up briefly in Uganda, but it was mainly mentioned in Zambia. This was from community members when we were asking them how they generally support the community health workers, and utilisation of the services they provide was obviously the main thing they did, because they don't financially support them, the community, although community health workers felt that they would like financial support from their communities. But what we found is some examples of where the community came together to try and help them out. There did seem to be a real understanding that being a community health worker does take time away from family activities, other income generating activities, and so that tended to be the area where people tended to respond in terms of community action. Cultivating plots of land was the one that came up most frequently, and I'm trying to remember if there were others, but they were sort of similar. I think there may have been one where they talked about chickens. But it was the sort of livelihood areas where people provided support. Yep.
Okay. It's the gentleman in the middle, and then Sylvia.
Hi, Zaimul Haq from Save the Children. Thank you for the presentation. You talked about drug systems, drug management. So 3 things actually. So you mentioned that the drug supply can come through the public health system. So I'm wondering which countries have, if Malaria Consortium was supplying ICCM drugs throughout the project duration, are there systems in place or supplies in place where the Ministry of Health is now going to replenish those drugs going forward? 1. Secondly, were the community health workers trained on effectively managing drugs? Were they aware of temperature control, or where to put those drugs, or those sort of things? And thirdly, did you look at is there a system in place where monthly projections were being compared with consumption, and which was being compared with utilization of community health workers? Thanks.
Okay, all right. I think, Claire, and then maybe, go ahead.
I was going to say, I'll say something brief, but because really your questions relate to what we did at the early stage and implementation, it's probably Helen and James to probably respond in more detail. But in terms of what I can say from what the respondents said, we did try and integrate the commodity distribution as much as we could through the existing public health systems, and there did appear to be a mixed opinion about whether we should do that, because some people felt that it would be, certainly at the community level, it'd be better for them if the drugs or the commodities came straight to the community level. But in some ways that conflicts with our aim of working through the public health system, so that's why we try to maintain that focus. And certainly if we couldn't do it at the beginning, we try to do it progressively over the course of the project. In terms of training, I think in terms of storage and managing the supplies, I think I'll hand over to Helen or to James. And I think he can also maybe make a comment about data in terms of comparing consumption data and how that informs quantification, which I think was the question, but please clarify if I didn't get you right.
Yep. Okay, James.
The effective management of the medicines or the drugs is one component in the training package that the community health workers undergo or undertake, but it is limited to what they need to handle for that particular course. So much of the other is left to the supervisors or the health facility health workers, who need to manage the stock in terms of knowing how much to replenish them, and then the consumption, how much we need to order, and the consumption based on how much they have used per particular month. Being a community health workers, if you delve so much, or the knowledge you pass over to him in terms of managing the stock management, you need to be cautious on how much you give the community health worker. So you don't want to go so deep. You just need to say how much have you used, what are the losses, what are the reasons for the losses, how much do you need this particular month, when are they expiring, when do you use, what is the first expire, first use. So the little stock management information is passed over to the community health workers, and the other is left to the health worker. So the link between the formal health system or the primary health care system and the community, the ICCM or community health workers need to be strengthened to be able to manage medicines. That should be left more to the supportive supervision.
Okay, all right. At least he's touched on that. Sylvia, could I just take maybe like 2 questions from the web, and then we'll come to you and move on to the next session. Eleni?
We have a question from Musonda Kasonde at UNICEF, who asks, were there any key lessons learned around commodity availability and supply chain? And a question from Esther Thaler, asking what happened in communities where IMCI was already being implemented. How did you balance between IMCI and ICCM?
All right, so Claire, do you want to touch on those?
I'm just referring to my presentation again around the lessons learned on commodity and supply chain. I think the main ones were, the main ones are really in relation to what really happened in practice in relation to distribution of the drugs and commodities through the public health system, and things such as the exchange in Zambia between the ones sort of at the health facility and ones intended for ICCM. There was a lot of learnings around stockouts in terms of particularly how the stockouts negatively impacted ICCM at the community level where they did exist. And I think probably it's important to say when we talk about stockouts that the stockout periods were certainly not consistent. There were small periods of stockout, which inevitably does happen, but we did everything we can to ensure a regular supply. But at times there were stockout periods, and I think it's inevitable that people do raise these because it's something which is so impactful. And I think around the acceptability really of the commodities at the community level, they were the things which really came out the most in that area. I hope that does answer the question. In relation to IMCI, I wonder, Eleni, whether you could just ask that question again.
I think it was talking about IMCI and ICCM. How do we make the balance? I think the slight confusion there is IMCI is at facility, where ICCM is at community level, and I think the presenters have stressed the fact that we really have to keep that link between the facility and the community together. And I think James pointed out that IMCI trained health workers end up being better supervisors and better capable to work with community health workers implementing ICCM. Okay, Sylvia, please.
Thanks. I was interested in the points that you brought up on data use. The 2 points. One was about the health workers needing to be better able to use data, and then the point about how to get the community health workers give the data more value. But I just wondered if there were any sort of specific ideas, suggestions that came up as to how to make that happen, because it's quite challenging to work out how you can engender that.
I'm getting my head across all the data. It's just so many quotes I have in my head. I think a lot of people said at the health facility and sub-national level that it's about training and regular support supervision. So people taking the time, maybe at regular planning cycles, say at the year point where you look at evaluating the performance over the last year and looking at developing work plans over the next year, of having support at that point so you can look at data, look at trends. I think at the health facility level, they mainly talked about of people coming through sports supervision and giving time to that. At the community level, they didn't talk so much about data directly, because for them, I think it was more about their role in it at the time. But I think what came out from analysing the data is that they don't place as much value as we would hope in the data itself. And I think further up the system, I think it was mentioned that I think at subnational levels and certainly health facility levels, that if the community health workers themselves appreciated more the importance of it, then they'd be more likely to do, to ensure the timeliness and quality. And I think to me that points to sort of how we can summarise the data and provide a feedback loop. But I think they were the areas that suggestions focused on.
Yeah, and I think just to mention that at some point, I think, Karen, in your presentation, you're going to highlight some ways in which we're doing that. Okay, I'd like to move on to James Sechtoleko's presentation.